Today we'll be looking at the pathophysiological classification of anemias. All anemias are due either to excessive blood loss, decreased red blood cell synthesis, or hemolysis. Anemias. There are many ways to analyze them, which can lead to confusion. Today we're going to be looking at several methods, but we will be looking at a specific method that you can use in clinical practice. The general principle is you want to look at your CBC, come up with a simple differential diagnosis from the blood count as well as the blood film appearances, direct your clinical inquiries towards the diagnoses, and then order appropriate lab tests to confirm your diagnosis. The blood count, concentrate on 4 parameters: the hemoglobin, which will tell us if the patient is anemic based on population averages, the MCV, which will tell us the type of anemia, the MCH, which will tell us if it's hypochromic or normochromic, and then the reticulocyte count. Here is an example of a nice way that you can do your workups with patients with anemia. All adults must be screened for the occult blood test. If this is positive, you can identify and treat the cause of bleeding. However, if the occult blood test is negative, you then look at the MCV to differentiate microcytic, normocytic, macrocytic. And under each one of these would be the additional testing that you would do based on the MCV. As you can see, for some, you might only have to do the serum ferritin and the TIBC, whereas with macrocytic, you would be looking at serum B12, folate, and TSH. Anemias can also be classified by the cytometric schemes, such as the cell size and hemoglobin contents, such as the MCV and MCHC, the erythrokinetic schemes, and the biochemical molecular schemes. On the complete blood count, look again. The MCV, if it is less than 80, that's usually caused by iron deficiency anemia or anemia of chronic diseases. If it's larger than 100, it will be caused by vitamin B12 deficiency or folate deficiency, and if the MCV is normal, it will be caused by renal, liver, or thyroid diseases, as well as those above. WBC and platelets will tell us if there's a primary marrow production problem. Peripheral smears can identify whether or not there is something wrong with the actual cells, such as in a hemolytic disease. The reticulocyte count will tell us whether or not there is an inadequate production in the presence of anemia, increased production but unclear whether or not it is appropriate, or inadequate responses. When we look at the different ways we can classify anemia in sickle cell, if we use the cytometric classification, it would be normochromic, normocytic. Erythrokinetic classification would be hemolytic, whereas the molecular would be the mutation of the DNA in the hemoglobin chain. It's easy to see how you can become confused. We generally will use the cytometric parameters and hopefully the biochemical. Signs and symptoms of anemia are well known. It depends on how rapid the onset is, what the underlying disease is, and how it affects the hemodynamic stability of the patient. As you know, it can be very asymptomatic if it's mild or chronic. Fatigue is a common symptom. In adult patients, always check for a heme-positive stool, since GI blood loss is a common cause of anemia. This means you must do a rectal exam or get stool samples. For elderly patients, the manifestations of anemia may be many. It can be depression, impaired cognition, insomnia, syncopal weakness, loss of appetite. Don't forget this with your workup in elderly patients. Signs and symptoms for the skin of anemia can be coolness, pallor, jaundice, spoon-shaped nails. Cognitively, it can be altered mental status or neuropathy. For someone with sickle cell anemia, it may be bone or joint pain, enlarged liver, spleen, or enlarged lymph nodes. For everyone, it could be shortness of breath with exercise, chest pain, passing out, high pulse rates, or postural hypertension. This is a slide of normal RBCs. Notice how they have a zone of central pallor about 1/3 the size of the RBC. You will also see some small fuzzy blue platelets, and in the center of the field are a band neutrophil on the left and segmented neutrophil on the right. You have to understand the RBC development to understand anemia. It starts in the bone marrow, where you have the pluripotent stem cell, which then will become more individualized. It will become the erythroid cell, pro-erythroblast, the erythroblast where it does have iron, finally going to the reticulocyte, into the circulation, and finally to the RBC. And here is another visual. If you notice, you're in the circulation, you will have reticulocytes and erythrocytes. Erythropoiesis is the formation of RBCs. This begins with the pluripotent stem cell, whose progeny are influenced by hormones to develop into several cell lines. One of these are the erythroid line of development. Normoblasts are characterized by increased hemoglobin synthesis, and during the late normoblast stage, the nucleus is ejected and the cell is called a reticulocyte. Factors necessary include erythropoietin, iron, vitamin B12, folic acid, vitamin C, vitamin B6, and amino acids. The normal RBC production is a never-ending cycle, with erythropoietin stimulating the bone marrow, making RBCs, which then affect the oxygen availability, which then stimulate the kidneys to make erythropoietin, and the cycle continues. Here is an example of small RBCs. If you notice, these are smaller and have an increased zone of central pallor when compared to the normal RBCs. These are hypochromic, microcytic. There is also increased anisocytosis, meaning variation in size, and poikilocytosis, variation in shape. The most common cause for hypochromic microcytic anemia is iron deficiency. The most common nutritional deficiency is lack of dietary iron. People at risk would be children, and particularly infants after their iron stores are used up after 6 months, and women in reproductive years who are losing menstrual blood or from the stress of pregnancy. This peripheral blood smear will show that this patient